And I see Kristen has joined us.
Hi, how are you?
I'm good. How are you?
I'm good.
Thank you so much for coming today. Kristen, I'm going to give you a little bit of intro because you are one of our past winners with the research grant, the CUASF, KCC, KCRNC, and I'm really excited to hear about your research and how it's developed. So Kristen McAlpine is a urologic oncologist at Credit Valley Hospital in Mississauga. She recently completed the Society of Urologic Oncology Fellowship at U of T, and you are still active at U of T. You're also completing a PhD in clinical epidemiology at the Institute of Health Policy Management and Evaluation at U of T, and is focusing on the use of machine learning to improve the personalization of care for patients with renal masses. And I believe that's what you won your grant research award for. And your research interests include personalizing the care of patients with urologic cancers, developing tools to improve shared decision-making for patients facing challenging decisions, and optimizing perioperative, and I'll never pronounce this, thromboprophylaxis. So I didn't do too bad. Strategies and accessing the outcomes of various urologic cancer surgeries. I also wanted to mention, because many of our patients have taken advantage of our 2 Ottawa Decision Aid booklets on the best treatment for small kidney tumors and should I have surgery to remove all or part of my kidney. And Kristen was one of the lead contributors on those booklets that we have on our website and available for our patients. So I will let you take it away, Kristen. I'm excited to hear about your research. Thanks for coming.
Oh, thank you very much. Thank you for having me. And it's so nice to be here today. And that introduction was very kind. So thank you very much. I'm just going to bring my slides up. But yes, this is the research that I'm doing for my PhD, and is also the one that was supported through KCC, KCRNC, and CUASF. So again, my name is Kristen McAlpine. I'm a urologic oncologist, and I work out of Mississauga and Toronto. And today I'll be presenting on a project that I'm working on, which is personalizing the care of patients with renal masses using machine learning. I have no conflicts of interest, but I have been on an ad board for Tolmer. So a bit of background. I'm a relatively new urologic oncologist. My practice is mostly out of Credit Valley, but I do have an appointment at Toronto General and Princess Margaret as well. I've been everywhere for my training: Waterloo, Queens, Ottawa, U of T, and I'm still in the middle of a PhD at the University of Toronto. So I'd like to start with a case presentation of a 68-year-old gentleman who's found to have a renal mass. Over here, we can see a CT scan. This is his right kidney, which looks normal, and the left kidney, this area is a mass in the left kidney. This gentleman does have some other medical conditions. He has high blood pressure, diabetes, and abnormal heart rate, and he is on a blood thinner. And at a baseline, he's known to have low renal function. He comes to his urologist and he asks, "What is the best option for me, doctor, to treat my renal mass?" As urologists and as a genitourinary oncology community, we know that there are several options for the management of smaller renal masses. These can range from active surveillance, where we monitor a mass with ultrasounds and CT scans every 6 to 12 months, all the way to removal of the entire kidney, removal of part of the kidney that includes the tumor, or something we call ablation, where we put a needle into the tumor and either heat or cool the tumor in order to kill the cells. It's very important to know that when we see patients and when patients come to a urologist, we are constantly balancing the pros and cons of different treatments. On one hand, we want to cure a potential cancer. However, on the other hand, we know that the treatments that we offer have potential side effects, and we don't want to cause side effects for something that may never have harmed a patient. So here's an example of some of the things that we think about when we see a new patient with a renal mass. So the pros or the cons, or the benefits and risks of surgery. So if the benefit is that we might avoid a delay to cure a potential cancer, but the risks are that the tumor might not be cancerous and that there's certainly risks of having a major surgery. A biopsy is an option where we put a needle in and try to take tissue out. And this would allow for a more personalized approach if we can get cells and it can tell us what type of tumor this is. However, not all biopsies can give us the cells that we need to tell us what type of tumor this is. And there are complications of biopsies, including bleeding around the kidney. Finally, something like surveillance, where we monitor the tumor. For many patients, this avoids overtreatment and avoids invasive surgery and ablation. However, it does leave a potentially cancerous tumor in place, which could lead to spreading and incurable disease. And for some patients, this leads to a significant amount of anxiety as their tumor has not been removed. So a little bit of background information specifically about these smaller kidney tumors. So when we talk about a small renal mass, we're talking about a tumor in the kidney that's less than 4 centimeters in size. About 80% of these tumors are cancerous, but 20% are not. So 1 in 5 patients who comes to us with a small kidney tumor does not actually have a cancerous tumor. Even the cancerous small renal masses, most of them behave in a non-aggressive fashion. However, all small renal masses have the potential to grow and could potentially spread to other parts of the body. When we see patients, we often are assessing for tumors that are larger and may contain aggressive cells, as these are more worrisome to us that they may grow or spread to other parts of the body. So when a urologist sees a new patient with a renal mass, there's several things that we're taking into account when we're deciding on what are the possible options that are available, and then discussing with the patient what are the next best steps in a shared decision-making manner. So some of the information that's really important for us is the patient factors. What other medical conditions do they have? What's their baseline kidney function? Are they on any medications? And essential to this discussion is what are that specific patient's values and preferences. For some patients, they really cannot stand having the tumor in place. And so they are very keen to go to surgery kind of regardless of whether this is a known cancer or not. And for other patients, they really don't want to have surgery, and they would accept a higher risk of the tumor growing or spreading in order to avoid a potentially major operation. And these are very important pieces of information for us to elicit when we're talking to a patient for the first time. With regards to the tumor, the size and location of the tumor matter. It helps us to plan surgery. It helps us to know how likely it is that the tumor is going to be aggressive. But another very important factor is trying to assess how likely it is that a tumor contains aggressive cells that might lead to spreading. This is a tool, and there are various tools that we can use, that a doctor can use to try to assess what the likelihood is that a renal mass contains cancerous cells, and what the likelihood is that the tumor contains aggressive cells, aggressive cancerous cells. So this is just one example. This is an online tool. And in this tool, the doctor would put in the patient's age, their sex, and then various characteristics about the mass. So this is how big the mass is. This is how far it's in the kidney versus extending outside of the kidney. And you can see that when we put all this information in, this tool tells the doctor there's a 79% chance that this tumor is cancerous, and there's a 33% chance that it contains aggressive cancer cells. Now, this sounds great, and this would solve the problem. However, there are issues. This tool only works about 70% of the time. And so as you can imagine, for a patient in the 30% of the time, maybe the tool is used and it says there's a very low chance that this is cancerous. The patient goes on surveillance, and then a few years later, it turns out the tumor has spread. And so it's not accurate all of the time, which is a bit worrisome. And then the second problem is that they tried to test this tool on different types of patient populations and found that it didn't work as well. So it doesn't apply to all patient populations, which again is worrisome when we're trying to apply a tool for patients with kidney cancer everywhere or kidney tumors everywhere. And so the question then is, how can artificial intelligence improve the care of patients with small renal masses? And that's the whole point of this talk. But before we dive into the details of the research that I'm doing, it's important to understand what we're talking about when we talk about artificial intelligence and machine learning and deep learning. These are two terms that are used very commonly in the popular media, in research presentations, but there's many times that it's difficult to understand exactly what people are talking about. So overall, artificial intelligence is the umbrella term. It's everything that has to do with a computer trying to act more like a human brain. So artificial intelligence is a program that can sense, reason, act, and adapt. And the excellent example is Siri. So Siri, you can say, hey, Siri, what's the weather outside? And Siri can respond. So it can sense, it can reason, and it can act. You can say, hey, Siri, tell me a joke. And again, it can sense what you're asking and it can give you a response. Those are all taught to Siri ahead of time. And so it's not actually learning at all. It's just understanding what you're saying and reiterating a response. Within artificial intelligence, a subset is known as machine learning. Now, machine learning is more of exactly like it says, it's learning based on the information that it's taught. So these are algorithms whose performance improve as they are exposed to more data over time. So as more information goes in, the output becomes more and more accurate. And the common example is Uber estimations. So you want to go to the hockey game, you go on your phone, you call up an Uber, and it tells you the nearest driver is 5 minutes away, and it's going to take you 20 minutes to get there. That information is based on the traffic in the area. It's based on other Uber users who have taken similar routes. It's based on the driver that you're getting. They know all the patterns of how these people are driving and how the traffic is to get different places because of all of the information that is going back into the Uber algorithm from other users. Finally, deep learning. So deep learning is the most specialized subset of machine learning. And what it is essentially, it's multi-layered networks that can learn and interact and act on their own. And the most perfect example is self-driving cars. And so the idea is that deep learning is the most human-like computer sensing and acting. So a self-driving car can sense a person on the road, it can sense another car, it can speed up, it can slow down, not from information that you're giving it, but because it's sensing the environment around it. And so that's all great information, but the obvious question is, so how does this apply to a patient with a renal mass? And so these are CT scans of 5 patients who have kidney tumors in their right kidney. All of these are small renal masses, but they all look very different on these CT scans. And right now, if a patient has a CT scan, you have a radiologist and a urologist eventually will look at these tumors and they'll say, this looks worrisome, or this looks like a cancer, or sometimes we'll even hear, this looks more like a papillary renal cell carcinoma. But there's vast amounts of information in these images that we're not fully accessing at this time. But a computer can do that, and a computer can analyze images to a much greater degree than a human eye can, which is why we go forward with what we call as radiomics. So radiomics is a subtype of machine learning. So again, it gets better with the more information that you put into it, the better it is at predicting the outcome that you want, like an Uber estimation. So radiomics is the statistical analysis of medical imaging. It's done with computers, and it's done to assess a specific part of the image that a researcher has to outline, which is known as a region of interest. And the outcome of interest has to be identified by the researcher as well. So here's an example. So a patient has a CT scan, just here. They have an X-ray or an ultrasound. And the doctor gets the images results. And this is a CT scan of a person's chest. And there's this area here that's what we're worried about. So a doctor would go and they would outline this area. And then those images would be put into a computer program, which looks at the radiomics, so a statistical analysis of the imaging. in order to provide an outcome. So the outcome being the likelihood that this is a cancerous mass, the likelihood that's an aggressive mass, and potential for what treatment options would be available for this individual. So here's an example of what I'm doing right now. And so this is a CT scan of a patient with a left renal mass. And so I've outlined the mass here in two parts of a CT scan. So we've outlined it, colored it in, outlined it, colored it in. And then this will go on to a specific program that will look at various parts of this tumor. And so what is the program looking at specifically? Well, it looks at many, many things that a human eye can't specifically look at or can't specifically put into a specific quantity. So for example, the radiomics program will look at the shape of the mass or the area of interest. So it'll look at how the volume, how big it is, the diameter, how spherical or not spherical it is. Then it looks at various other parts of the tumor. So this is called the first order statistical features. And essentially it's just saying how bright is the tumor on the picture in one area versus how bright is it on the CT scan in another area. And then it compares the areas. So this is the texture of the mass on the CT scan. So this is saying it's not very bright in one spot, it's more bright in another side, and how these all line up together helps us to understand, is this more likely to be a cancerous tumor? Is it more likely not to be a cancerous tumor? And then finally, there's some very high level mathematical equations and filters that are run within the computer program to identify pattern recognition. So again, it's important to know that the machine learning, we talk a lot about it, and many people explain it as a black box. You put the information in and it spits the information out, but really that's not totally accurate. The radiomics program helps us to look at information that we can't quantify with a human eye. But in order to create these algorithms with machine learning, you're actually incorporating a lot of patient information that we know is associated with both how likely it is that a tumor is cancerous and how likely it is that a tumor contains aggressive cancer cells. So, for example, you would include the patient's age, the patient's sex, and the diameter of the mass, but then you also add in these extra features, the heterogeneity of the mass, how intense the different pixels are in different things. So we're just adding more information. We're not reinventing the wheel. So let's go back to our first case with our 68-year-old gentleman who has a renal mass. Now, unfortunately, this gentleman has a bit of a tough decision because none of the options are great options for him. To have a biopsy, he'd have to stop his blood thinner, which might put him at risk of having a stroke. To have surgery, he's already known to have low kidney function, so it might put him also at the risk of having to need dialysis. Ablation, where we put a needle in and either burn or freeze the tumor, is challenging because this tumor is right near a very big artery and a big vein, and so there's the risk of major bleeding. And then surveillance, again, challenging because it's reaching kind of the top part of our cutoff of 4 centimeters where we just don't have a lot of information about monitoring patients with that size renal mass. And so this leads to exactly the research that I'm doing right now. And this is the research question that we're looking at. So for adult patients with a small renal mass, does the use of machine learning, which is through radiomics, to predict aggressive tumor cells compared to the current tools that we're using, which I talked about at the beginning, are about 70% accurate. Does that improve the ability to improve the personalization of patient care? And so this research is ongoing. But this is our end goal. This is what we're hoping for, and this is what we strive for when we're analyzing these CTs and looking for specific outcomes for patients. So we envision that a patient would come to their urologist. The urologist would collect information about the patient's age, their medical history, their values and preferences with regards to their renal mass. Then we would be able to look at their images. So often a CT scan could be an MRI or an ultrasound, and apply the algorithm. And we hope that our algorithm would be much more accurate than the tools that we're currently using. And it would tell this specific patient the likelihood that this is a non-aggressive cancer or a non-cancerous tumor is 15%, and the likelihood that this is an aggressive type of a cancer is 65%. And with that information, the urologist and the patient would have an informed, data-informed, shared decision-making approach to management. And for example, this patient may have chosen surgery because of the high risk of aggressive cancer cells. Now, artificial intelligence and machine learning are also being used in various other parts of kidney cancer research. So we've talked a little bit about using images to look at, is this a cancerous or a non-cancerous tumor? Is it an aggressive or a non-aggressive type of tumor? Even some researchers are looking at, can it tell what type of renal mass this is? Papillary, clear cell, maybe even angiomyolipoma. So that's research that's ongoing. Some other areas of interest, though, is looking at if we can predict how likely it is that a cancer recurs postoperatively. And I'll talk a little bit more about this one in the next few slides, but also about predicting response to systemic therapy. So maybe there's more information in the CT scan images that can help us to predict which patients are going to respond to systemic therapy and which ones are not, or which patients are going to respond to different systemic therapies versus another systemic therapy. So let's look at a second case, which will identify one of these other areas of machine learning for kidney cancer that I was just talking about. So this patient's a 55-year-old female. She has a large renal mass. She's otherwise healthy. She takes no medications, and she has a normal renal function. So this is her large kidney tumor. It's in the right kidney, and she goes on to have a radical nephrectomy. When the pathology comes back, it shows that she had a 15-centimeter aggressive clear cell renal cell carcinoma with negative margins. And the important clinical question, which you've already talked about in the last discussion as well, is should this patient now go on to have what we call adjuvant systemic therapy in the form of immunotherapy? So this was a study that we did out of the University of Toronto, so through Mount Sinai Hospital, as well as Toronto General Hospital. And this study was looking at predicting the recurrence risk of renal cell carcinoma after nephrectomy with the role of CT radiomics for adjuvant therapy decisions. These are the co-authors here. And the lead was Dr. Masoom Haider, who's a radiologist. So again, in this study, we did not start from square one. We used some of the tools that we already know help to predict whether a kidney cancer will recur. So it looks at the size, how aggressive the tumor is, various things that in the past researchers have shown can help to predict whether a kidney cancer will recur. But in addition to this, we then also looked at thousands of radiomics features. So remember, radiomics features are things that the computer can look at on a CT scan that the naked eye necessarily can't. So for example, how spherical the tumor is, how heterogeneous the tumor is, various parts of a CT scan that go in more depth than we can see with the naked human eye. And what we found here essentially is that including radiomics, it did improve our ability to predict whether cancer would recur or not. However, it wasn't a huge jump. You can see that there's a bit of an improvement here, but it wasn't a drastic improvement. And there was a number of reasons why we thought that may have occurred. Predicting recurrence is challenging. The numbers were a bit low. And the use of different types of CT scans, which I'll talk about in a bit, also makes this type of research challenging as well. So there are various potential benefits of using artificial intelligence and machine learning in kidney cancer research. We may be able to improve the accuracy of predictive models. So again, this is what I'm looking at to try to predict which tumors have aggressive cells and potentially need surgery versus which are unlikely to have aggressive cells and might be more suitable for surveillance. This will allow us to personalize the care of patients with kidney tumors. We may be able to improve even more on risk stratifying which patients would best benefit from adjuvant therapy after surgery. If we're able to develop a very accurate model based on CT scans alone, we might be able to avoid biopsies, which do have risks. And this is even more beneficial in areas, remote areas, where the centers are not used to doing renal mass biopsies. And so we don't often get results, or the patients have higher risks of complications. So the ability to look at a CT scan with machine learning in these centers would be even more beneficial. It improves access to equitable care for a smaller center, and it allows us to do international collaborations because everyone not everyone, but many people have access to CT scans. And so we can speak in a universal language with individuals from across the world because we're looking at imaging. And this is something that could be freely available in the future to apply a program to a CT scan image to allow people to have, again, equitable access for international use. Now, not everything is great about machine learning and artificial intelligence, and there are some challenges. So one important challenge is that in order to have the computer learn about what type of tumor, what kind of outcome that you're interested in, you have to have very consistent imaging. So you can't compare a CT scan to an ultrasound to an MRI. They're too different. And also, even at different hospitals, the way that they do their CT scans, when they give contrast, it might be different compared to another center. So maybe in Hamilton, they give the contrast and they do the scan at 30 seconds. At Mississauga, maybe we do the contrast and scan the patient at 45 seconds. And in Toronto, they may do it at 60 seconds. Well, that tumor is going to look very different on those images if we have different amounts of contrast in it. And that is a challenge because, again, it's changing the consistency of the imaging that we're looking at. We also need thousands and thousands and thousands of patients to make these algorithms accurate. And one of the major limiting factors right now is there's lots of people who are doing machine learning research. They're trying to create what's called algorithms, or just a way that they can say that the computer can look at images and give us a result. And then we publish a paper, and that's great. But the limiting factor now is turning that into a clinical tool that a patient and a doctor can use in a clinic to look at a CT scan and to give an accurate outcome. That is a huge, huge limiting factor in machine learning research, and something that we're trying to break down that barrier for as well. Finally, two other important things that don't often get talked about are the ethics and legality of doing research in machine learning and artificial intelligence. So with regards to the ethics, again, like I mentioned, we need thousands and thousands of patients' images to create these algorithms. And so many patients would have been treated 20, 30 years ago, 15 years ago. They've had their treatment, they've had their surgery, and now they're doing fine. But those images that get included help to create these accurate algorithms, but they're not necessarily having a direct informed consent. And that's something that people worry about, whether that's ethical or not to include those images. Finally, legality. So say we create this tool, we publish it, we make it freely available. We say it's excellent, it's 99% accurate. And then somewhere a patient and a doctor in another country use our tool, they apply our tool, and it says, there's a very, very high chance that this tumor is not cancerous. And they say, well, that's great. Let's go on to surveillance. We're going to watch it. The likelihood that this is going to cause a problem is very low. And if something happened where the patient actually, in fact, did have a cancerous tumor, it then went on and got bigger and spread other places. There's a lot of discussion about who's responsible for that. Who is legally responsible for that patient now developing a poor outcome based on an algorithm that was supposed to be, or a tool that was supposed to be very accurate, and that was published to say it was very accurate. And so it's very important for everyone to know, doctors, patients, researchers, that nothing can be 100% perfect. And it is, there's always a degree of inaccuracy. And that's something that needs to be discussed on all levels when we're using these types of tools. So in conclusion, artificial intelligence and machine learning has the significant ability to improve personalization of care for patients with kidney tumors. To maximize our ability to use artificial intelligence, standardized collection of data and imaging will greatly improve the accuracy of models. And there's an ongoing discussion of ethical and legal implications of using artificial intelligence and machine learning-based tools to guide patient care, and it's greatly needed. So that's it. Thank you very much for inviting me, but also for your time and your attention. I'd be very happy to take any questions now. And these are two of my email addresses that if there's any questions after the forum or later today, please just take those and I'd be happy to discuss over email as well. Thank you.
Thank you so much. That was very informative. It looks promising, the future of kidney cancer. We are having comments in the chat that they think it's a great talk and they appreciate you sharing. It's interesting you brought up the legalities. It is always a challenge, isn't it, going forward? But we as kidney cancer patients know, I think more so than some other cancers, as kidney cancer is truly a unique disease. And what is often so predictable is not really what we think it will be. But I'm sure these challenges, you'll find ways to overcome them. And this looks very promising, especially for patients with comorbidities and the small tumor aspect. And I know people get sometimes frightened with the word active surveillance, but in my case and in Andrew Weller's, who's is a little bit different, but we're both long-term active surveillance patients, and it takes a little getting used to it first, but really it's not as terrible as you might think. And sometimes it's good to catch your breath and have an opportunity to look at all your treatment options and what might be going forward. So thank you so much for sharing, and I look forward to seeing how this develops. It's very futuristic.
It's very exciting. It's the future for sure. And there's just so much information that we're not fully capturing that. Yeah. Kidney cancer is like you mentioned, it's so multifaceted. There's so many aspects of it. We as a urologist, we have discussions about challenging cases, difficult situations, patients with comorbidities all the time. So it's not, we have difficult decisions on our end too, because it is this true risk of benefit versus harm. We're trying to first do no harm, of course. These surgeries can be challenging. And so any tool that we can get that can improve our ability to inform a patient and improve the informed decision-making, it should just continue to move the field forward and continue to empower our patients to make the right decisions.
I agree, and thank you. And I truly appreciate your words, empower the patient, because you are one of those that truly listen to the patient voice and value the patient voice, and that's so important to us. So we really appreciate it. Thank you for coming today. It's good to see you.
Have a great weekend. Thanks.
You too. Take care.